We'll moving on to panel discussion on managing early lung cancer patients, which will be moderated by Dr. Tajinder Singh. And we have on panel Dr. Praveen Paliwal, Dr. Amol Dongre, and Dr. Sameer Srirangwa. Oh, so if you can take over.
I think I'm audible right now. No?
Yes, sir. Yes, sir. Audible.
So Akash is also there in the board?
Yes, sir.
Yes, sir, I'm there.
So Akash is there, Dr. Praveen is there, Nikhil and Dr. Sunit is there, right?
Sunit?
Yes.
Dr. Sunit is there?
No, sir. Dr. Amol and Dr. Sameer Srirangwa, sir.
So you have right now Dr. Akash is there.
Yes, sir.
And Dr. Amol is there. And
Yeah.
Dr. Yes, sir.
So only 3 people are there.
And Dr. Sameer, sir.
Okay, Sameer is there. All the
Yes,
speakers
sir.
are there. Okay.
Yes, sir.
So I need not ask any question. Everyone has already answered it, right? So Amol, Akash gave a very vibrant talk on the role of what you call as looking at the disease, that there's a big role of cancer screening, right?
Yeah.
And he also made a comment that after the recent COVID thing has come, you are seeing an increase in the lung cancer patients and you are getting more number of patients. How much is the truth in your practice?
So,
Pardon?
You are seeing more number of patients of lung cancer post-COVID.
Yeah.
You are getting more patients?
Yeah.
what,
Basically, it's not about
sir,
getting
sorry
more,
to cut you short.
but
No, Akash, I am just telling that the number of CT scans have increased. So we are seeing little bit slightly increase in the incidence of lung cancer in your
We are
practice.
seeing them a little earlier, sir. So
Earlier.
that's what I meant.
So you are getting now more early cases.
So,
as
sir,
compared to
in my as in my practice, we remember that say till 2019-20, we had only one surgery for lung cancer in our center. In this past, we are a low volume center at a private center. We've had almost 4 patients who have been operated for CA lung. What I meant is that because there were so many CTs happening, there are certain patients who were picked up early.
Okay.
That small nodule.
No,
Not only
I'm
for
not
lung
saying,
cancer, but
I
a
am
lot
not
of
saying
other-
anything. Reason is that I have not seen an increase in the early lung cancer. That's the reason I'm
Okay.
asking.
Okay. Sure.
So, Amol, what is your take on this early lung cancer in the last 1.5 years in your practice because of so much of CTs going on?
But yeah, so as rightly said by Dr. Akash also, it's not like we are seeing increased number of lung cancers, but yes, since because of this COVID, lot many patients underwent CT scan, and now we got at least I mean, if previously it is like 1 patient, now we are getting 3 to 4 patients of lung cancer. I won't say we are getting much early stages, but yes, the incidence of lung cancer has definitely increased after this COVID PET.
Early lung cancer.
Yeah.
So Dr. Praveen and Dr. Sameer, what is your take on your practice because of COVID thing? You are seeing more number of early lung cancer now?
Not really, sir. So
yeah. Okay, fine. And what about Dr. Sameer? Sameer, I think is working in NCI, no? Sameer is there or he has left?
He's working in NCI.
NCI. Okay, fine. So anyway, I think this is a point which everyone has highlighted, looking at the overall survival outcome, and we tend to see more number of patients in stage 4 only, getting, even though we have so many meetings of stage 3, but finding too much of stage 3 is near impossible. We tend to see more of stage 4. Stage 1 and 2 do come, but in the last 1 year, I'll say 1 patient only had come for adjuvant therapy. So I am not seeing so much, but it depends upon center to center. It depends upon how well known is your basically the surgeon from the thoracic side. If you have the high volume, then they get, like our places like Asia Cancer Institute in the private setting, there are more number of patients who are basically there you get more number of lung cancer patients. So, but yes, we talk about overall survival with the stage. Less the stage, more the survival, more the stage, less chance for the survival. So that is what I was asking in the thing. Now, Dr. Akash, you are working in a place where I think you have a good number of patients on lung cancer. Now, looking at the stage 1, 2, 3, I'm not talking about 4. So what is the percentage in your clinical practice?
So, sir, stage 1, 2, we rarely see. We see almost 10-15% of our population would be stage 2, 1 occasionally. So, as I told you, an operated lung cancer, we remember seeing 1 in the practice. In recent times, we have seen more. Stage 3, not particularly, but stage 3 in general, around 30%, a majority of them are stage 4. So that's how.
Okay. So basically, you will say if suppose 30% are stage 3, stage 1 and 2, 10%, nearly 60% are stage 4.
Yeah.
So 60% are stage 4. Amol?
Majority.
Yeah, so I have never seen a stage 1 lung cancer, to be very frank. Stage 3, yes, almost
No,
10.
you have to find a patient whom you have to give adjuvant therapy, right?
Yeah. So, stage 1 I have not seen. Stage 2, yes, I have given adjuvant chemotherapy to only 2 patients in my last 7 years career in Nagpur.
Yeah, that's the truth.
Yeah, stage 3, there are a lot many. Like we give NSCT followed by CTRT in such patient. Won't say stage 3, but yes, stage 3 I have seen. Still 2 patients undergoing NSCT followed by CTRT.
Stage 4 is constituting how much percentage in your practice? Stage 4.
I would say almost 80%.
80%. So you say that it is 80%, approximately 15% stage 3 and 5% of stage 1,
Sure.
maybe less.
Yeah.
So okay. So Dr. Praveen, what is your how is the practice different from Amol, or you are same like
Same, sir. So, same. So I will say around 80-85% stage 4, 15% stage 3. That also more for the concurrent or the sequential chemo RT. Less than 5% that is comes into rare category, stage 1 or stage 2, sir.
Yeah, I'm finding very difficult.
Last patient I've seen that was in the pre-COVID era, sir. That was a large cell adenocarcinoma, large cell cancer.
So anyway, I think the stage 3 is very difficult to find, even though, Amol has told that there are some here and there patients do come for the new adjuvant chemotherapy, but bulk of our patient, more than 80%, I will say more than 85% are stage 4. Stage 1, like Amol said, you have to literally find, in a year, if you get it, you will be lucky. Otherwise, sometimes you get, sometimes you don't get, like that over there. So now, Amol, in the era of mediastinal staging and EBUS, you go for EBUS or you go for mediastinal staging? That is pathological.
Yeah, definitely we go for EBUS. Mediastinoscope is a bit difficult, it's invasive. So EBUS is a good technology, and we just refer for EBUS only.
Yeah, I think now the people who are now recently trained for the EBUS, they are quite smart. Most of the people, they know the nodal stations. Some of the nodal stations are difficult to assess by the EBUS, but somehow I felt the technology is much better. Akash, any other take in your institute? You are the one who is seeing the maximum number of early stage.
So, sir, this is how we do it: PET plus EBUS. So we follow our institutional practice. The practice at our training institute, we follow the same in the private institute.
So I think everyone is going ahead with the pulmonologist, wherever the lung thoracic surgeons are there. Basically, EBUS has come into every city now, and people are not quite well trained. Pulmonologists are quite well trained in that. Now, looking at the management, right? We have 3 questions for all of you. Most of the patient getting 1 is very rare, but still it is further divided into stage 1A and 1B. And 1B is a very delicate area, and you have stage 2 and stage 3. We'll just ask the question to everyone. Akash, stage 1B, surgery alone or surgery followed by chemotherapy?
So, sir, surgery alone, chemotherapy is doubtful. So we use it. So we know more than 4 centimeters now stage 2A in the new classification. So we use it in poorly differentiated tumors, LVI positive. There we
so basically you look at the
criteria is to give adjuvant chemo there, plus minus adjuvant chemo.
Okay, so you look at what is important is that you look at high risk features and take a call separately. Amol?
Yeah, so definitely rightly said. Surgery followed by adjuvant chemotherapy is what I would prefer for a stage 1B patient.
Right.
Yeah.
So only for the high risk patients you will go for it, because most of the trials have been excluding 1B in most of the trials. If even if you see the adjuvant now immunotherapy trial and osimertinib trial, everything is excluding the stage 1B also. They are all going for 2 and above.
Yeah.
Right. Samir, anything different from here? Dr. Samir?
Hello. Yes, sir.
Stage 1B. I think you had taken a class for stage 1B for us also, no?
No, sir. I presented a case that.
You presented a funny case of dual mutation, right? I remember.
Yeah, right, sir. Right. Yeah.
So stage
So,
1B,
sir,
you go for chemo or no?
More than 4 centimeters. So as per new classification, not, but as per old, yes.
Okay, great. So what you do for stage 2? You go ahead and give chemo plus surgery. Post surgery, you go for chemo.
Sir, if it is more than 4 centimeter, definitely chemo.
Yeah, I think
And
there are some things which every one of us know. Stage 1B is something where we normally look at high risk feature. Based on that, we decide on the adjuvant chemotherapy. We'll come to the other points later on. And stage 2 is similarly managed as like stage 1B. Role of post-op radiation is limited to only certain indications. And stage 3A, basically, I think most of us do go for, depending upon, based on the tumor board decision regarding looking at the role of new adjuvant chemotherapy. The role of adjuvant chemotherapy here is not so well defined, and role of post-op radiation is also not so much defined. So these are the trials basically which laid the foundation for chemotherapy. I think all of us know about this, that the benefit is not so great. It is, but still OS advantage of around 8.6. Remember, the trials which have come up in the recently looking at the molecular markers and the immunotherapy, they have not shown any OS benefit. But the previous trial of adjuvant chemotherapy had shown an OS benefit, even though it was hardly 8.6% at 5 years. So looking at the question about, now a patient is referred to you and the patient has got early stage lung cancer and very bad comorbid features, he cannot take chemotherapy. What you will do? Amol?
Early lung cancer, exactly. I would like to know what's the stage of the patient.
Stage 2.
So would definitely go ahead with the CTRT for this patient if he is prohibit surgery, or would like to give him neoadjuvant chemotherapy followed by CTRT.
Post-surgery. This is post-surgery. Post-surgery.
Pardon?
Post-surgery. I will say post-surgery. I'm putting one more condition. The patient has got stage 2 disease post-surgery, but not fit enough for taking chemotherapy.
And so in that case, I know I'm talking about the early stage lung cancer, but still would like to know the molecular status and would be offering him, maybe a oral therapy if at all he's positive for some biomarkers.
Okay. So have you ever in your practice given any patient treatment based on the molecular markers? Early lung cancer?
I wouldn't say early lung cancer, but definitely a curable lung cancer. I would include, stage 3 patient in that, because I'm still giving one gynecologist from Nagpur who underwent NSCLC surgery, and now I'm giving this thing, molecular, basically targeted therapy as a maintenance. I have not given her chemotherapy to this because she has positive ALK1. So, yeah.
So even though the data is not so strong for giving adjuvant for ALK positive, any therapy is there or not?
Yeah.
So you have not given that patient, because there is no big role for basically, honestly, a role of adjuvant chemotherapy in a stage.
And in fact, neoadjuvant, she didn't respond the way she should respond. So even though she underwent surgery at Mumbai only, but then we opted for, adjuvant targeted therapy rather than going for chemotherapy.
Right. So Dr. Samir, any experience like what Amol told, that some places you decide based on the molecular therapy, molecular markers?
Adjuvant, I haven't treated any patient with any targeted therapy, but we have data for osimertinib, which is really fascinating. But for ALK, I'm not very sure. We don't have any data, I think, here. So it will be all experimental basis, or we can say it is like compassionate basis rather than any evidence-based medicine.
So apart from this ALK and EGFR, you do an extensive panel testing, or you just go ahead with a limited panel testing, or you don't do at all?
Ideally, you should test only EGFR, sir. If you want to.
What about PDL1? What about PDL1?
PDL1, sir, yes, definitely.
Now
Definitely
data is there for PDL1 also.
definitely. Yeah, definitely data is for PDL1 positive. More than 10%, I think there is a good benefit.
Okay, so it is more than 1%. Honestly, the trial has shown for.
But greater benefit was in, I think, more than 10, something like.
Yeah, but the approval came from more than 1%. If I'm
but
right.
1 to 10, I think benefit was not that great. Means it was more than 10 and then more than 1. So the benefit in 1 to 10% is mainly driven by more than 10.
So you, if given a choice, you will go for only limited testing. You will not go for extensive testing, right?
No, sir. Like BRAF, we have a data. BRAF mutation is positive. The high risk of
I'm just
recurrence.
asking, in your practice, do you go for BRAF testing?
No, sir. In practice, I would not.
Will you do the P53 testing also?
No.
Okay.
It won't change the management.
There is a lot of data about P53, how it will affect the chemotherapy, how the BRAF, KRAS basically will affect the chemotherapy. But in your routine practice, in an early lung cancer patient, post chemotherapy or prior to starting chemotherapy, you do NGS or not? That is what I was asking.
No, not doing. Hardly seeing any early lung cancer patient. But definitely, I'm not that aware because we hardly see any early stage lung cancer.
So you are working in a big institute here, NCM में patient तो रहेंगे अभी बहुत सारे.
Sir, बहुत है, but early कोई नहीं आता sir. Rarely, hardly. One or in a year or two, one single patient maybe.
Okay, and that's the truth here. Whether you are Akash, what is your take on early lung cancer doing a biomarker testing? If at all, which test you do, or you do go for a full extensive NGS?
So, sir, two parts to it. So, based on pure evidence, there only limited markers have a utility. We know that with EGFR, we'll be able to do something with PDL1. But in my practice, if I have to I send the whole panel. The reason being, sir, we have seen sometimes when these patients relapse, they lose either the blocks, or at that time, sometimes the biopsy is difficult. So we explain the patient that it may not have any utility now, may never have a utility. But because they have become very affordable, we ask them to get the full panel done using a coupon.
Okay, so you go for a panel like 300 genes or 18 genes, 12 genes.
This limited panel with the Lal Path Lab ke saath, tie-up ke saath, we do this limited panel with
the 12 gene panel, the one which we normally do it for 9,000, 10,000 rupees, right?
So the reason we do it that way is that we think that logistically it will be easier for us. That is the sole reason.
So it all depends. And remember one thing, most of the mutations do change over a period of time. I think Samir had presented a very good case where, repeating a biopsy makes a lot of significance. Our job should not be that we should do it at the early so that the same panel, same test will remain positive over a period of time. They might change over a period of time. Right, Samir?
Yes, sir. Means tumor is always a heterogeneous tumor. We can have different clone with different driver mutations. So I think it's wise to do a fresh testing rather than relying on any old tumor tissue.
Depending upon how early the disease comes back, but
Yeah, right.
Yeah. So that's what I meant. SID we do it earlier so that if suppose later a biopsy is not feasible, ऐसा नहीं हो कि tissue block भी घूम जाए और biopsy भी feasible.
So you always have a liquid biopsy option.
Right. And liquid biopsy is quite good in lung, if you ask me, as compared. Even though EGFR it makes a lot of difference, ALK and ROS are very poor on the liquid biopsy. This point also we need to remember. ALK and ROS are not so great on the liquid biopsy. So anyway, what I think everyone knows is that if we are really trying to see the benefit, right now the data is only to do the EGFR and the PDL1. The rest of the markers also, there is no real data about P53, EGFR, KRAS, and looking at ALK also. There is no ideally a guideline to look for it. It all becomes very clumsy. When somebody has already ordered an extensive NGS and patient has done surgery, stage 2 disease, then you have to give adjuvant chemotherapy. Patient is ALK positive, whether you will add ALK or not. The case which Amol described was more of, a case where neoadjuvant chemotherapy patient was not responding. This patient had come to me also, Amol, to take an opinion also. And and later on patient underwent surgery, and the ALK positive, based on the ALK positive, we had given the basically anti-ALK therapy over there. So the data is basically more of limited, but yes, it makes you tinker our head more when you send it for extensive testing over there. So I think we will not go too much into the neoadjuvant therapy in early stage. The role is not so much well defined, even though we do go for a certain, we mostly go for cisplatin based, and it's mostly based on the toxicity and everything. But normally the role of neoadjuvant immunotherapy and TKIs, has anyone practiced in their practice in the right now? Amol?
No. Neoadjuvant TKI or IO, never.
Never. So I think Samir and Dr. Akash.
No, sir, not in my practice.
No, I think no one has gone ahead with the role of any neoadjuvant therapy. Sometimes in a very old patient, early stage case, we do go ahead with the TKI therapy if they are not fit surgically or medically, they are inoperable and they are not fit for any other therapy like radiofrequency ablation or radiation. Very rarely we tend to give it for patients who are like 84, 85, having ILD and other things, we tend to give it sometimes. So these are the randomized phase 3 study looking at the role of neoadjuvant therapy, surgery alone. This I think was already previously put up, will not go too much into it. And this was these were the trials which were shown to us looking at the emerging role of neoadjuvant immunotherapy long way ahead, before we can really say that this data will ultimately translate into the approval. And but so much success has happened in the role of immunotherapy that we do tend to see that we can use it for the neoadjuvant therapy. Long way ahead, I will say. So adjuvant therapy, basically the routine practice, like stage 1B, stage 2A, 2B, 3A, we go ahead with mostly chemotherapy. Where will you put the role of TKIs, Amol? I think we have data now.
Yeah, so
you give importance to OS or you go for the DFS?
So in a curative setting, it's always OS, which is more important, I guess.
So OS, the data is not very strong for the ADAURA.
Yeah, it's not strong, but if you ask me from this slide, maybe, I would prefer giving adjuvant TKIs probably beyond stage 2B, 2B3A. I would rather go for adjuvant therapy as TKI. But yes, it's only after giving adjuvant chemotherapy.
Okay, so you will go for a patient to give first chemotherapy followed by TKI.
I will follow the protocol of adjuvant chemotherapy, and then if at all it's positive, then I would definitely go ahead with the oral TKI.
Akash?
No evidence for that.
I know.
But beyond 2B.
And what about the role of atezolizumab here? One more thing I should put it here.
Well, I mean, I've just used it in metastatic settings, so actually no data. No idea.
Okay, so there is a data. There's a data which Samir was mentioning about it, right, Samir?
Sir, but I would say if driver mutation is positive, always better to do it with the target therapy.
No, I'm not talking. Driver mutation is negative. PDL1
if
is
negative, then you should do a CPS PDL1 score and then you decide according to the report.
Right. So basically, right now the data is there that anyone more than 1%, basically based on the IM power 010 trial, you can ideally, what he said is very right, more than 10% benefit is more, but the approval has come based on the DFS, even though the OS data is not mature, right? And
right.
And this they have given after chemotherapy, remember. So that is what I was telling. The IM power had first given chemotherapy minimum 4 cycles, then they had given the immunotherapy.
Right.
So Akash, anything will you give a chemotherapy and followed by TKIs in a EGFR mutant patient, or you will directly start on the TKIs? No adjuvant chemotherapy.
Chemotherapy followed by TKI. The reason we say that, even though the benefit of chemotherapy is small, it is a OS benefit. So, and in the ADAURA trial, there are both patients, their population who had received chemo, not received chemo. So if the patient is fit eligible for chemotherapy followed by EGFR TKI.
Right. So any patient you have enrolled for the osimertinib in the last few years?
Sir, so it was a patient who was started for osimertinib from Tata, and we are continuing here. But
Okay.
not our own patient.
Okay, fine. I think it's not so common to
An
have
adjuvant.
patient for 3 years because the cost of 3 years is quite heavy. And recently osimertinib is also, the Bangladeshi variety is also becoming very difficult to get the drug. So there is no OS benefit with the osimertinib, even though the benefit of DFS is quite clear on the scale, which we all know. And this is the data for the ADORA, looking at overall survival, looking at the DFS also. We'll not, the important thing to remember is the hazard ratio for the DFS is quite excellent. It's going up to 0.12, 0.16, which is something which we normally tend to see it. So Amol, how much you believe in ADORA?
Well, sir, if you see, the data is really, I mean, it's a good data. So I think we should be considering. I mean, I'm for this ADORA trial. I'm positive for this.
Even I feel what you said is very right. Sometimes the patient turn out to be ROS1 positive, ALK positive. There are no strong evidence, no strong data. But I strongly feel, more than EGFR, these two markers are very strongly, they respond very well to the therapies also, anti-ALK therapy and with the crizotinib and other whatever. So I think I felt that ADORA has a place. Only thing is the cost is a question which we need to think about. Looking at the question of adjuvant osimertinib in stage 1B also, I think we know that 1B is a disease which is quite difficult because no one has done a trial really looking into the role of adjuvant osimertinib. So my question to Dr. Praveen is that will you give the patient any kind of adjuvant osimertinib in early stage like 1B?
Correct, sir. As you shown, sir, because recurrence rate is still in the 1B is high. So after explaining the patient, so I will offer the osimertinib, sir.
No. So will you go for 2 years, 3 years, or because there's no data for any years? Or you'll just go for 3 years based on the previous data?
Based on ADORA trials, whatever. Because
so you will go for 3 years.
Yes, sir.
So any personal experience of giving osimertinib in your patient?
No,
Not
sir.
1B, like
No, no, sir.
No.
The best part is now that they are coming up with reduced pricing. They have approval for reduced pricing, and maybe the cost of therapy, which was going up to 1.7, is coming down to 1 lakh now.
That is still also high, no?
Still high, but yeah, but still.
And the best and the worst part is, I think, sir, patent is for 2031. So it is a long patent for the AstraZeneca.
So we always have a Bangladeshi.
So AstraZeneca. It's a long way for the generic to come, sir.
So Amol, you are attending a Astra meeting and talking about Bangladeshi variety.
No, I'm just telling you.
anyway, this is a recorded meeting. Your words are getting recorded over there also.
No, I had a discussion with them, and the main reason I told them is the cost, because it's really difficult if you don't have empaneled patient. See, to be very frank, if you have empanelment, that's okay, but otherwise giving it is quite difficult. And that's the reason they gave me a good news that they are coming, slashing down the price. So that's good.
Yeah. So basically, when I started practice long time back, IRESA was the only thing available in 2009, and they used to give it for 1.5 lakhs. So, but not too many trials were there also, except for the IPAS trial was going on at that time. But after the gefetinib came into place in a generic form, the usability increased a lot.
Yeah.
So I think the usability increases once you start decreasing the cost. Osimertinib is a wonderful drug. I think it has got a lot of place, but the cost is a hindrance for us to use it.
But Astra people have never reduced the cost of IRESA.
Yes.
Yeah,
they never. The last day.
Yeah.
So till it went away.
Yeah.
Totally.
Yeah, that's why it went away, but they never reduced the cost.
Yeah, I think anyway, I think we'll not go too much. We are running short of time. So we know that the adjuvant chemotherapy is the backbone of treating lung cancer, and skipping is very difficult. Everyone was of the opinion that skipping adjuvant chemotherapy is very difficult. That is a place. Adjuvant chemotherapy has got its own place. Adding TKIs and immunotherapy is something which we can do it based on the molecular markers. So this question I think Samir had already answered. If patient has got a driver mutation in PDL1, mostly we will go for looking at the driver mutation. If patient is EGFR negative and PDL1 positive, then only we will go for the role of immunotherapy. Based on this trial, IMpower 010, this was a phase 3 global study of ATI versus best supportive care post 4 cycles of chemotherapy, which we were discussing. A patient who had got a PDL1 more than 1%, basically you can see the DFS improvement at 24 months and 36 months. And the hazard ratio was 0.66 with a very significant p-value. And this was intention to treat population also. So this patient basically showed a very good improvement in the if the PDL1 status was more than 50%, but the advantage was seen more than 1%, especially in more than 10%. So lastly, a comment from everyone, Dr. Praveen, looking at the lung cancer screening, how commonly in your institute people are doing this lung cancer screening?
We are not doing routinely, sir. So any screening, maybe it is breast or cervical or lung cancer, it is more individualized, not the mass level, sir. So so the patient asks for, then only offer, or the patient especially asks, we discuss, then only offer. Because I think the physician, the chest physician, the MD medicine person, they should be aware that there is something known as low dose CT scan screening.
Low dose, most of the time it is not available also, honestly. They don't do it.
Correct, sir. So although, because correct, even the radiologists also don't know about the low dose CT scan. So that is the hindrance, sir. Then it's still the cost, like Akash mentioned, cost, the interpretation, then the how to follow up, and the how to apply at the mass level. There's so many things are there, sir.
Yeah. So
Even
Samir, Dr. Praveen.
If only if somebody asks for, because if there is a high risk patient, and then we offer for the somebody asks, in the family, sir, we have a person who is not having lung cancer, but he's smoker. What we can do? So we then try to offer, but obviously it is difficult to follow up, sir.
Yeah, and second thing is very difficult to tell them how much commonly they have to do it. Whether to do it 6 monthly, 1 yearly, it's a question which is always in the background, especially for the smokers and other thing. So, Dr. Samir, any take on whether we should really look into the guidelines which are mentioned in West and passing on to us? Hello. So, Akash, what is you had given a very nice talk on lung cancer screening, but you do it regularly in your place?
No, sir. So, sir, we not as a part of screening protocol, sir, but what we do is that if a smoker comes, a heavy smoker, we do ask them to get a CT once at least.
Great.
So how we follow them up is like the IPN strategy. If they have a nodule, small nodule, we ask them to follow. So that is how we encourage people.
Basically, it is you have to tell your institute.
Not screening. And national screening program, I firmly believe that there should be no national screening program for CL lung in our health setup.
So that is what, one thing is that if you see the health packages of most of the places, we are seeing in our institute basically around pickup rate for around breast cancer malignancy because of so much routine screening is around 2%, right? Which they used to come through the health package. Most of the time they come, many places, now the hospitals are going through so much common health package. So the breast cancer, basically the mammography is helping us in finding a newly diagnosed case of nearly 2%. Lung cancer, if you see, basically there is no package per se by any insurance company. So I think it's a long way ahead, but we need to say, and there is nothing called low dose CT scan. It is not so easy, to tell the radiologist to pinpoint. So we believe in normal CT, not for the low dose kind of CT scan. Anyway, thank you everyone. I think it was wonderful discussion. Thank you to all the panelists for actively participating in the panel discussion. Thank you.
Thanks, Dr. Tajinder. Thank you.
Thanks.
Thank you, sir. Thank you so much for the panel discussion and moderating the panel discussion. And thank you so much, panelists, for active discussion. It was a good discussion on managing the early lung cancer patients. I will request all the participants to, if you can please answer these two poll questions before we end the meeting. Thank you everyone for joining in. We'll close this meeting. Good night.